All right, so we'll keep going with the pathophys of the heart, and we're going to move on to diseases of the electrical system. And so for here, we're going to be talking about our arrhythmias. So just as a reminder, kind of a refresher of how we get the electrical signal to move through our heart. The cells of our heart are very unique in that they will spontaneously depolarize, which is really cool. It means they'll hit threshold and get an action potential all on their own. They don't need a nerve to tell them to do it. And in fact, if you take myocytes and grow them in a petri dish, the myocytes will begin to beat and contract at their own intrinsic rate. So different cells in different parts of the heart will depolarize at different rates, meaning some of them will depolarize much faster than others. And the fastest cells in all of the heart live in the SA node, up here kind of in the top corner of the atria. The sinoatrial node, or SA node, is called the pacemaker of the cell simply because it's the fastest. And because it's the fastest, it will have an action potential at a quicker rate than the other cells within the heart. Now, the reason this matters is that unlike skeletal muscle, where the cells are kind of separated from each other by their membrane, myocytes are all connected. They're what we call a functional succinction. The cells in between myocytes have gap junctions. So they talk to each other. When one myocyte experiences depolarization, it will automatically spread to its neighboring myocyte because there are gap junctions between. So when we have this change in ions that cause the cell to become more positive, right, that positive signal can spread to the next myocyte down the road. So the heart beats, the rate of our heartbeats is matched to whichever cell happens to depolarize the fastest. Because once one cell depolarizes, that signal is going to spread through the whole heart because all the cells are connected. So it originates in the SA node, and then there are conduction fibers within the atrial wall and internodal pathway. You can see that here is kind of a yellow area. So the SA node fires, and that action potential is spread along the conduction fibers within the atrial wall and the internodal pathway. When that signal gets to the AV node, the atrioventricular node, there's a really important pause that occurs. The AV node slows down the signal. And it does this because of a difference in the number of gap junctions in the AV node. There are fewer there, so it takes longer for the signal to move through. But this is really important for timing because it causes a delay between the atrial contraction and the ventricular contraction. So if you coordinate what's happening in the heart with what we see on the EKG, and this is going to be a very simplistic, just sort of pointing out the waves, we will go through EKG interpretation in cardiopulm. So for those of you who have not had it as part of your undergrad, that is still coming. This is not it, what we're doing here. But when you look at the waves that show up on an EKG, they represent the electrical signal or the electrical activity in the heart. And the P wave is the first little bump that we see off the isoelectric line, and that coordinates to the atrial depolarization. A little positive deflection showing that wave of positive signal that goes through the atria. Then there is this delayed flat part where there's no activity at all. And this really represents the time where the signal is, I was going to say trapped isn't probably the right word. The time that it takes for the signal to move through the AV node is a little kind of a flat part on our EKG where the signal is trapped just long enough to allow the atria to contract first, and then the signal gets across the AV node and makes it into the ventricle. Once we cross the AV node, there are the Purkinje fibers. In this picture, they're the yellow kind of cord-like images. Purkinje fibers have extremely high velocity of conduction. So once the signal gets through the AV node, it flies through the ventricle, both sides, just kind of flies along those Purkinje fibers. And the QRS signal represents that ventricular depolarization. The whole ventricle depolarizes, and then the cells will repolarize, right? Get back to their resting membrane potential. And the repolarization of the atria really occurs while the ventricle is contracting. So there is no waveform for it. It's kind of hidden because this big, huge ventricular activity drowns out any electrical signal of the atria repolarizing. But the T wave here represents the ventricle repolarization. So that's just sort of an aerial view reminder of the conduction system of the heart. Key takeaways are that the whole heart is connected as a functional succinction. So once one cell depolarizes, they'll all follow that lead. When the system is operating normally, our signal originates with the SA node simply because the cells of the SA node depolarize the fastest. And then it follows kind of our nodal pathways to first wave through the atria, causing an atrial contraction. And the only reason that we get the atrial contraction before the ventricle is because it takes longer for the signal to get through the AV node. But that delay allows what we call as the primer pump, right? Right before systole, the atria contract and it kind of plumps out the ventricle, puts a little stretch on the ventricle wall, and adds that little extra boost that's really helpful once the heart becomes functioning at higher levels. So let's go through some really basic arrhythmias. We will have a very in-depth arrhythmia discussion and lectures in cardiopulm, but I want you to give you the kind of the big ones, the garden variety ones that you will likely encounter prior to your first clinical. So bradycardia is a phenomenon where you have a slower than normal heart rate. So for these slides, I'm going to have normal sinus rhythm up at the top, and so that you can compare it to the abnormality on the bottom, which is bradycardia. Bradycardia is considered an arrhythmia, even though it has a regular rhythm. They kind of push them all into the same category. Bradycardia is defined as less than 60 beats per minute, which is kind of easy to remember because normal heart rate is 60 to 100. So if it's lower than normal, it's bradycardic. The typical reason someone has bradycardia could be that they have a problem with the SA node. So because the SA node is what drives our heart rate, if there's some kind of problem at the SA node where the impulses are being generated at a slower rate, it could present itself as bradycardia. This can sometimes be evidence of a block somewhere in the system. So we said that all the cells have to be connected and that wave of electrical signal just goes through all the cells. If there's anything that blocks that signal, it might slow down the rate. And this is actually a common finding in trained athletes. Highly trained athletes actually have a bigger heart and more blood volume. They don't need to beat as often, so they have a much slower heart rate, and that's totally physiological and a good thing, actually. So tachycardia is just the opposite. It's an elevated heart rate. So tachycardia is defined as greater than 100 beats per minute, which again is handy because 60 to 100 is normal. Tachycardia seen here is again a normal rhythm, just much faster than normal. So what you see on the EKG on the bottom of the slide is actually the physiological response to sympathetic activation. So it's not necessarily a bad thing. It's what you'd expect to see when the sympathetic nervous system is firing. You can see a tachycardia when someone has a fever. This is also the evidence that we talked about with a pulmonary embolism, that they become tachycardic. The next two are just common arrhythmias that you may encounter in an outpatient setting or an inpatient setting. Probably some of the most common arrhythmias that you will see. And the first is atrial flutter. So atrial flutter is when you have what's called a reentrant circuit. Reentrant circuit. And it is kind of illustrated as this circle, this kind of ring in the picture here. What happens is there is some kind of abnormality in the atrial wall or some kind of disturbance, and instead of the signal going in straight lines like you see in the normal where it follows the internodal pathways, the electrical activation takes a circular path where you get an action potential, and instead of going straight towards the AV node, it takes a kind of a circuitous route around. And since it's a domino effect, right, it activates, it ends up reactivating itself. And because the electrical impulse travels in a circle and it reactivates the starting point, it creates an endless loop. There is no time for this to go away, because as soon as the beginning repolarizes, the activation loop is back and it turns it back on. So electrical impulses spin around in a loop, creating a section of the atria that continues to fire and contract over and over again. So the SA node normally controls the heart rate. But in this case, this endless loop is going to cause a signal to fire at a much, much faster rate. You don't have to wait for the SA node to repolarize and then depolarize again. You're going to get a really, really fast atrial rate of contraction. In fact, in atrial flutter, it is normal to see an atrial rate greater than 200 to 400 beats per minute. Super, super fast. Now, the reason we see this type of arrhythmia commonly and in the outpatient setting is this actually isn't as bad as it sounds. People don't normally die from atrial flutter because the AV node keeps the atria kind of electrically separate from the ventricle. So even though this atria is contracting at 200 to 400 beats per minute, not every one of those signals is getting through the ventricle. Some of them are. When it hits the AV node slowly transmit the signal to the ventricle, and the ventricle will contract. So you're likely to see a higher than normal heart rate, but not all of the signals will get through. So ventricular rate is still normal, still kind of relatively normal. And by that, the clinical implication of that is, as long as the ventricle is having enough time between beats to fill, they're probably not having any clinical symptoms. So patients can feel this sometimes. They can kind of feel the flutter in the chest or the racing of their heart, but it is unlikely during normal ADL type activities where this would impact cardiac output to have symptoms like that. When you look at the EKG for atrial flutter, again, normal is at top. This is normal. On the bottom, you can see atrial flutter. So the P wave on the EKG represented atrial depolarization. In atrial flutter, the atria is going through many cycles of depolarization, more than the ventricle. So you see what is referred to as a sawtooth pattern, because it kind of looks like the teeth of a serrated knife. What you see is multiple P waves, more P waves than QRSs, because the atria is depolarizing many times and just a few are getting through for ventricular depolarization. Atrial fibrillation is a very similar concept, except instead of having one reentrant circuit, you have many reentrant circuits. So the cartoon version of this is you see many of these circular activation patterns. So every one of these is creating its own little endless loop of activation. So because there's many reentrant circuits, you can get atrial rates greater than 400 beats per minute in atrial fibrillation. But again, due to the refractory period in the AV node, the ventricles will get no faster than 100 to 150 beats per minute because they're protected by that slower conduction in the AV node. So atrial fib kind of is a more irritated atria and can be more problematic, but it still has a limited severity in a patient's life depending on their activity level. When you look at the EKG now, where in atrial flutter, we saw a bunch of P waves. In atrial fibrillation, there's no coordinated electrical signal coming from the atria. By that I mean we get an EKG by putting electrical pads on our skin. So the electrical activity has to travel, through the tissues of our body to get up to the skin. The reason we can actually get enough of a coordinated electrical signal to deflect the EKG and get a wave is because a big hunk of muscle is contracting all at the same time. With the fibrillation, little sections are having all their own little depolarization. There's never enough to coordinate for one big signal large enough to deviate the line of the EKG. So in atrial fibrillation, we actually see either absent or erratic P waves, kind of more of like a fine wavy line than true P waves that you would see in flutter. So patients can end up in atrial flutter and atrial fibrillation for a number of causes, but anything that kind of disrupts the health of the heart. So probably one of the most common causes is coronary artery disease, where there's been frequent bouts of ischemia can leave the heart vulnerable to these types of arrhythmias. Valvular disease, hypertension are all common causes of atrial flutter and fibrillation. I say that only to put this in context for you and not something to write down and memorize for a test, but just to kind of appreciate that when things start going wrong in the heart, it can lead to damage to the cells that can present itself as an arrhythmia. Now, for both of these patients on atrial flutter and atrial fibrillation, speaking of tying it into other concepts, these patients are at risk for forming blood clots in their heart. Now, the reason for that is because the atria is kind of separated from the ventricle and not moving the blood in a continuous way, blood can kind of be in the atria and sort of get shook up, right? Especially with fibrillation. The atria is just sort of quivering and kind of shaking the blood back and forth. That is a great environment for coagulation factors to sort of bang into each other and become activated. So patients who have atrial flutter and fibrillation are frequently put on anticoagulation meds to prevent that activation of the coagulation cascade. So again, very brief introduction of the arrhythmias. There's many, many more, and we will go into, I kind of left all the fatal arrhythmias off because they're not things that we normally deal with in therapy, hopefully. We will talk about them again, as I mentioned, in cardiopulm. So the next umbrella of diseases that happen to the heart are all related to the blood flow to the heart. So these are vascular diseases of the heart. And let's jump into it. So to understand how someone can get into trouble with vascular disease, it's important to have our minds around the anatomy of the blood flow or the coronary circulation. So the right coronary artery is the main artery that feeds the right side of the heart. So it comes off of the aorta and heads over to feed the right side of the heart. This is also the blood supply to the SA node, which can be important because the SA node drives our heart rate. And then the left coronary artery, right, is the big branch that comes off the aorta and then splits into the left circumflex artery, which I always think that kind of makes sense, circumflex kind of wrapping around. And it goes to the left atria, it hits the left ventricle's lateral and posterior walls, kind of wraps around the back. So circumflex goes around the back to the lateral and posterior walls of the ventricle. And left anterior descending tells you right in the name where it goes. It is the large anterior wall of the ventricle. So obviously the heart is the pump for the circulation. of our peripheral circulation. But the cells of the heart don't receive their blood supply from the blood that's within the atria and the ventricles, right? That's within the chamber of the heart. The individual cells receive the blood flow from their coronary arteries. So when we start talking about disruption of blood flow to cells of the heart, we're talking about some problem within these, external arteries that actually feed the oxygen demand of the myocardium, because you need to have the arterial divide off into the capillaries to actually have the gas exchange. Now, this is a really critical, important concept in understanding vascular disease. I think everybody who's listening to this knows that our heart gets oxygen from the blood. And if you increase the work of the heart, if you make it beat harder and faster, it will need more oxygen. Now, unlike skeletal muscle, the way the myocytes handle oxygen is actually very different than skeletal muscle. In your skeletal muscle, let's say in your legs, blood flows by your muscle and you do not take all of the oxygen out. In fact, you don't take very much out at all at rest. Like maybe 20-30% you take out and the rest just floats by and that oxygen just goes around and around for the ride. In the heart, even if you're sitting very quietly and your heart is not beating hard, it extracts all of the oxygen out at rest. So the oxygen that went in, right, on the venous end, there's no oxygen left. The reason that matters is because when you need to deliver more oxygen, there's no ability for the heart to just extract more. It can't take more oxygen out of the blood. It's already taking all the oxygen out at rest. The only way to increase oxygen delivery is to increase flow, blood flow, vasodilate. That's very different than our skeletal muscle. Like in our legs, one of the first things that we do when we need more oxygen is just extract more. Oxygen extraction can go up with exercise, and we'll talk about it in phys of activity, but those of you who are in ex-phys are probably very familiar with this concept of all the things that can increase extraction. It's not here in the heart. We extract almost maximal at rest. So when we need more, we have to be able to increase blood flow. Things get even more critical for the myocytes because cardiac myocytes are a type of cell that almost exclusively use mitochondrial oxidative phosphorylation for their ATP production. So this is not a cell type that is protected by stored glycogen. So there's no way really to make ATP effectively without oxygen. So myocytes rely on oxidative phosphorylation for ATP production. And the only way to deliver more oxygen to those cells that need oxygen to make ATP is to increase the flow. These two concepts come together. The fact that it's a flow-limited system and the cells rely on oxidative phosphorylation, they really come together and kind of explain the prevalence of myocardial damage due to vascular disease. So the good news is for the pathophys of coronary artery disease, you already know it. Coronary artery disease is just atherosclerosis in the coronary vessels. The steps are the same, everything is the same. It's just atherosclerosis in this particular area. Another name for the process by which we get coronary artery disease is ischemic heart disease. And someone has ischemic heart disease due to coronary artery disease because of the imbalance between cardiac blood supply or perfusion and myocardial oxygen requirements. So if your vessel looks like this, you're going to have a worse ability to deliver blood flow. We should put it maybe down. Blood flow goes down. If you can't deliver blood flow and your coronary and your cardiac myocytes need oxygen, you're going to experience a mismatch between supply and demand. The myocytes will demand more oxygen than this crowded up vessel can supply. So coronary artery disease is caused by atherosclerosis, but it's important to remember kind of what this looks like clinically. And I don't know if I actually talked about this first bullet point when we talked about atherosclerosis, but atherosclerosis has no symptoms. We don't have pain receptors in the walls of our blood vessels, which, thank goodness, I always think this is a funny concept. If you think about if we did have some kind of pain receptors in our blood vessels, then every time you exercised and your blood pressure went up, you'd be like in misery. Because the pressure goes up and all your pain receptors would be screaming. So it's good that we don't have pain receptors. We don't want to feel pain every time we've got pressure in our blood vessels. But that also means there's no warning for atherosclerosis. This might look ugly and nasty, but we do not feel it. We have no idea that it's there. We only have symptoms of coronary artery disease once we have a critical reduction in blood supply. And that's really important. And this is why we're already very, very, very far down the road into a disease by the time we have our first symptoms. Because typically, coronary artery disease is unnoticed until it's 75% blocked. That's a lot. The flip side of that is, isn't it amazing, like how wonderful we were created, that we've got all of this room for error, that our heart can keep on going with only 25% of the lumen available? That's pretty awesome. The negative is this vessel is going to be very blocked already by the time they first notice it. So how does it present itself? It can present itself, and we'll go through each of these. It can present itself as angina pectoris. That is intermittent chest pain in relation to activity. So as you increase demand, you have a little chest pain. As you calm down, it goes away. Myocardial infarction, as infarction implies, it's a true lack of blood flow, which actually has cellular death involved. And then third is the unfortunate, the first manifestation of this can just be sudden death. That is the first time there'd be any symptom, that it becomes a critical lack of blood supply that kills the person. So let's first talk about angina pectoris. As it says in your notes, it is insufficient blood flow to the heart muscle. It's from narrowing of coronary vessels, and the sensation people experience is chest pain. So what's happening here is there's some kind of increased oxygen demand. So a person is walking up the stairs or walking, on a grocery store that's much bigger than they normally do. There's increased demand, but then these atherosclerotic vessels are clogged with plaque and very stiff. So they're not going to really respond to vasodilation very well. And they cannot increase the blood flow to meet the increased oxygen demand. And I like this cartoon on the figure where you can see the normal healthy vessel. And then a person who has atherosclerosis, there's plaque there, but they're asymptomatic in that there's no disruption, there's no mismatch between supply and demand at this point. They have plaque, but no symptoms because they're still able to meet the oxygen demands of the heart. Once that plaque gets bigger, now we start to have problems when we need to increase flow. So stable angina is the term given when we have chest pain in response to a predictable cause. And you'll hear that in your patient's story is they'll say, oh, I'm pretty good, but if I walk up more than a flight of stairs, I'll start to get chest pain if I don't sit down and take a break. So they know that 2 flights of stairs will be the kind of threshold they can't meet. There'll be a mismatch between supply and demand. And the chest pain won't go away until they rest, and they decrease oxygen demand of the heart. So kind of a common finding or a necessary finding in stable angina is that the cause is predictable. It's in response to a known stimulus. The next thing is that the symptoms will reduce with rest. We need to have decreased symptoms with rest. And what that tells you is that it is a supply and demand issue, because as you reduce demand of the heart with rest, the amount of lumen that's available here can meet the demands of rest, and the ischemia will go away. And these patients have to be pain-free at rest. If they're having ischemic pain at rest, this would not be stable angina. It has to be in response to a stimulus, because it is a phenomenon that's caused from mismatch, and you shouldn't be having that at rest. Now, in your notes, point number 2, it says Prince-Metal angina. I just want to step out of traditional angina just for a second to introduce this atypical variant that exists but is very, very different from coronary artery disease. So in my notes, I put like a big box around this and wrote atypical, really big. Like, this is just a separate thing that is also angina, but from a very different cause. Okay, so we're stepping out of coronary artery disease just for a second, because Prince-Metal angina is ischemic chest pain, but it is from coronary vasospasm. So the coronary vessels have smooth muscle in them. If the smooth muscle spasms, it will constrict down on the vessel and reduce blood flow and cause chest pain. So it's angina because it's a chest pain from, blood oxygen mismatch between supply and demand in the heart, but the cause is completely different. It's typically not associated with exertion. It most often occurs very early in the morning, where they're experiencing chest pain in the morning, again, not in relation to exertion. These patients rarely have classic cardiovascular risk factors because it's not a coronary artery disease. So it's a separate thing. I want it to be on your radar that there is other forms of angina that are not coronary artery disease. These patients would typically be treated with calcium channel blockers, because the cause of the disease is a vasospasm. So if you block the calcium, you would block the ability of the smooth muscle to constrict, and that can often take care of the symptoms. So that is a little aside in your notes, but I just wanted to put those right by each other, the two types of angina. All right, so for stable angina, which is associated with coronary artery disease, patients are either treated to reduce cardiac demand, right? Because the disease is caused, or the symptoms are caused from a mismatch of supply and demand. So if you can quiet the heart down, so beta blockers block beta adrenergic receptors. So if you block beta adrenergic receptors, you basically block the effects of the sympathetic nervous system on the heart. So in that way, beta blockers can reduce heart rate. Calcium channel blockers can reduce both heart rate and contractility. But for both of these drugs, if you reduce the oxygen demand of the heart, then even though they have limited ability to deliver flow, they can meet that demand because you're blocking the increased demand with the drug. The opposite of that, or not the opposite, the other option that we have is to improve blood supply. So by treating them with a vasodilator, you can improve blood flow to the heart. Other things that you will typically see is education and intervention to change diet and lifestyle. People will often go on cholesterol-lowering drugs. Statins is the big one, to try to prevent the further growth of their atherosclerosis. And they'll often be put on antiplatelets, because the atherosclerosis grows on the arterial side. So the mechanism of blood clots that form is more likely to be a platelet aggregation clot as opposed to a coagulation cascade. So aspirin, and this is just the full name for Plavix, which is kind of one of our big antiplatelets. So it's just some things to put on your radar for stable angina. Is this is one that can get tricky with skeletal muscle injuries. So you can have, if you strain or injure your external abdominal obliques or your pecs, that can often mimic angina because it's in the chest region. If you're doing activity, you might be using your arms or taking big breath that actually kind of pulls on that muscle. And it can, because chest pain is such a well-known symptom, sometimes patients can be worried that they're experiencing angina. Trigger points can sometimes be confused with coronary insufficiency. And that coronary insufficiency is a kind of the way we say the mismatch between supply and demand. So it's just good to know that as a PT, when we're trying to discern the difference between musculoskeletal origins of pain and organ pathology of any kind, in this particular one we're talking about cardiac pathology, if your pain is of musculoskeletal origin, you should be able to recreate it in your PT evaluation. So pain of musculoskeletal origin, if you push on it or contract it or pull it, you should be able to recreate the pain. If you can't recreate the pain during your evaluation, that is a bad sign that maybe you're dealing with something like referred pain. So by using your skills, you can very confidently, you might not be able to diagnose the coronary pathology, but you can certainly be an expert in differentiating whether it is or is not musculoskeletal pain. And that can be incredibly powerful. I mean, you can be the one that gets somebody into a doctor sooner because you identified and you're the expert in musculoskeletal pain. There's really no one that knows it better than us. And you'll be the one that can tell the difference. So that's stable angina. And that's something we encounter a lot. People walk around with stable angina. It is certainly a warning that, if you have stable angina, you have atherosclerosis. That might be a wait and see, right? Treat it with diet and lifestyle and statins and kind of see if it progresses over time. What we're worried about is that it will progress and eventually become unstable angina. Once we've crossed over to unstable angina, and this you'll notice in your notes, it's under the heading of acute coronary syndrome. Because once it is unstable angina, it is considered acute coronary syndrome. And acute coronary syndrome is a sudden decrease or block in blood flow to the heart. Most often, when someone experiences a sudden decrease or block of blood flow to the heart, it's because of an abrupt change in their plaque, either an erosion or a rupture, that causes a thrombosis. So it's very likely that somebody had stable angina, they had their blood vessel with the plaque in the walls that was causing a very predictable response to exertion, and then there was a sudden disruption in the plaque that caused a clot. I should actually change my color here. Plaque erodes, it gets ruptured, and you suddenly get a blood clot from the lipid core of the plaque being exposed to blood elements. And you suddenly have a decreased blood flow. We are experiencing an acute coronary syndrome. Because this is a sudden change in blood flow, unstable angina is characterized as having symptoms without exertion. So where stable angina is chest pain in response to a predictable known stimulus due to oxygen supply and demand mismatch, unstable angina is chest pain in response to cardiac insufficiency or oxygen supply and demand mismatch, but it's not related to exertion. Pain at rest, sudden pain at rest. Now, the only difference between unstable angina and a myocardial infarction or a heart attack is that there is a sudden drop in blood flow, right, from the clot, but it is not so occluded that it causes cell death. So it's really the exact same story as a heart attack, except there's still just enough flow getting through that there's no cell death. So we're going to tie back into our Unit 1 conversation on cell injury and death here when we start talking about what happens in different versions of acute coronary syndrome. So unstable angina is a sudden reduction or block in blood flow to the heart to cause symptoms in no relation to exertion or activity. They do not go away with rest, but the obstruction to flow, while serious to cause ischemia, is not so bad where it results in cell death. When you have a full-blown myocardial infarction, you have a true blockage of blood flow to an area of the heart that causes necrosis of myocardial tissue. So it's the same story that we saw with unstable angina. It's a form of acute coronary syndrome. So this is the plaque that's in this blood vessel. There is a disruption in the plaque, whether it erodes or ruptures, and you get a sudden blood clot in the vessel. And this blood clot completely obstructs flow or has a much larger effect on flow than we saw with unstable angina. So there is a phenomenon where, the plaque can grow into the vessel and completely block it. But most of the time when you have a myocardial infarction, the plaque has gotten so big that it gets disrupted, and that's why you get the sudden symptoms of a myocardial infarction. And, now that I say that, I should clarify that it really is impossible to predict which plaque will rupture from a clinical perspective. There's really no way to say, oh, your plaque looks like it's about to go. It's just, in fact, 2/3 of ruptured plaque are less than 50% stenotic. So it's completely unpredictable. And I know no one likes that in medicine, and it's frustrating, but that's why you should always be on the lookout for cardiovascular risk factors, because if they have the risk factors, it's very likely they have plaque. And if they have plaque, you got to be watching for signs and symptoms of myocardial ischemia. So there's a huge lack of predictability here that is just comes with the territory, and that's why we have to be hyper vigilant. Now you'll see in your notes there's two types of myocardial infarction. I'm going to draw it my way first, and then on the next slide I have kind of the textbook picture, so we'll, whichever one works the best for you, but I'm going to draw this out first. So we describe a myocardial infarction as a subendocardial MI or a transmural MI. So I'm just going to draw the heart. I'll go a little more anatomical this time than I have done in other diagrams. So here we have kind of a cross section of the heart. I'm going to erase this in a second, but just so you're oriented, right? This is the ventricle wall. This is the ventricle, right? This is where the blood goes. Obviously, that's the left. There's the right ventricle. Okay. Not being in person, sometimes it's hard to tell if you guys can orient to that. Okay, so here's a cross section of the heart. The coronary vessels, right, are on the outside. I mean, not exactly like that, but the coronary vessels run on the outside of the heart. And so they have to have branches, right, that have to come off to feed the ventricle wall. So I'm going to zoom in on this. I'm going to kind of I'm going to take this and I'm going to zoom in. So here is the ventricle wall. This is the ventricle here on the inside. And here is our coronary vessel. Now, in a subendocardial MI, the coronary vessel gets a blood clot, but it doesn't completely occlude flow. So my purple addition is meant to be the clot. And if this coronary vessel gives blood to, let's say, this whole area here, and there have to be, right, branches that come across, and oxygen has to diffuse all the way across the wall of the ventricle, you can see that the area of the ventricular wall that's farthest away from the blood supply is the endocardium, right? So that's, let's make this. So this is the endocardium of the heart, the inside of the ventricle, as opposed to the epicardium where the coronary vessel is. So that's the farthest away from the blood supply. So if this coronary vessel gets occluded, the entire tissue will be ischemic. But the farthest away is going to be the most infarcted. Because if there's oxygen traveling, it's going to first oxygenate the tissue that's closest to the blood supply, and the further away you go, the less and less oxygen that we have. So in a subendocardial MI, it's not a complete occlusion. There's some blood flow getting through. So the cells farthest away from the blood cell are the cells that end up dying. As opposed to a transmural. So I'll redraw this same. Here's the ventricle. Here's the wall of the ventricle. This is the ventricle here. I'll make our endocardium yellow again so we're oriented. Here is our coronary vessel. And in a transmural MI, the entire coronary artery is blocked. There's no lumen showing at all. Complete occlusion. So if this vessel, right, was giving oxygen to everything in this area of the ventricle, all of these cells are infarcted with no blood supply and will undergo cell death. So a transmural MI is a full thickness MI. The entire thickness of the wall experiences cell death. As opposed to a subendocardial MI, only the most inner part of the ventricular wall experiences cell death. So the textbook version of this same description includes all three of the phenomenon that falls under an acute coronary syndrome. Unstable angina has the plaque and the small clot, the small platelet disruption and aggregation, which disrupts blood flow but not enough for cell death. And then you have the two types of MI. And I really like this picture of the heart to illustrate how the distance that the oxygen has to flow, right? If the clot forms here, the tissue that's farthest away is going to be the first that dies. So in a subendocardial MI, there's some lumen still available. I'm not kind of pointing to the clot. Let's try that again. This is the lumen. There's some lumen still available. So there is cell death because it's an MI. Myocardial infarction means there's going to be cell death. But the area furthest away in terms of the ventricle wall, the endocardium, is where the cell death will take place. As opposed to a transmural MI, the whole thing is clot. It's a complete occlusion. It's a full thickness MI. Now, when artery becomes occluded, there is a non-uniform effect, right? Because the main area, which is in my cartoony pictures that had the cell death, is called the zone of infarction. This is the area where there's a true infarction of blood flow. There's no flow getting there, and those cells are going to die. So in a subendocardial MI, we're talking about the endocardium will experience cell death, but the cells closer to the epicardium will not be so infarcted. They'll get some oxygen. The zone of hypoxic injury are the cells that are getting insufficient oxygen, but they're not so hypoxic that they die. So this is in Unit 1, when we went through the steps of hypoxic injury. We talked about all those nasty things that can happen to their sodium transporters and their intracellular calcium homeostasis, and there's upregulation of phospholipase and proteases, and the cells are really starting to look kind of ugly, but it was reversible cellular injury. That is the zone of hypoxic injury. If you restore oxygen to these cells before they cross into irreversible cell injury, they can go completely back to normal. An important thing to think about here is when we're thinking about the steps from Unit 1 of hypoxic cellular injury. During the time of the MI, while the cells are undergoing hypoxic injury, they are not functioning normally. Let me say that again. The cells that during the MI are experiencing hypoxic injury, they are not functioning normally. So in this case, the job of these cells is to contract and contribute to the stroke volume. During the hypoxic injury, the cells that are hypoxic will not be contracting because they're just trying not to die. They're not doing any extra work right now. So cardiac function during the heart attack will be much, much worse than what could potentially be their function once blood flow is restored and those cells are able to function again. The cells in the zone of infarction aren't contracting either, but they never will. They're never going to come back. That tissue will be replaced with a scar, right? It typically takes about 6 to 8 weeks to have a true scar laid down and formed. So that area will be vulnerable for about 6 to 8 weeks while that scar is forming. But that tissue will never come back. And then the zone of ischemia is kind of the area around the infarction. So in our vascular system, if we've got 2 different arteries, we have branches that come off, and there's definitely like a web type situation where there's a lot of cross into which vessel is oxygenating which tissue. So if you get a blood clot in this coronary vessel, the neighboring vessel still has normal blood flow, so it might be able to deliver oxygen to kind of the tissue in the middle. This is supposed to be maybe oxygen squirting out or blood. I think that's meant to be blood. So the tissue in the middle might experience some ischemia, but it's got this other vessel to kind of cover it a little bit. Whereas the tissue, kind of on this side that has no other vessels providing any oxygen is the tissue that's hypoxic and infarcting. Now, an important thing about these zones is that they are not static, right? And that's kind of what I was kind of hinting at with hypoxic injury. If a cell is hypoxic for too long, it will kind of transition into irreversible cell death. So the longer that the person is experiencing the occlusion, their zone of hypoxic injury will transition into an infarcted zone. Another way of saying that is the infarcted zone will get bigger and bigger and bigger over time. More cells will experience cell death. And there's cells that are in the zone of ischemia that might start to undergo hypoxic injury because of the length of time that it's living in that low oxygen state. So our myocytes have about 20 to 40 minutes that they will tolerate ischemia before they start going into irreversible damage and experience that coagulative necrosis. So it is a race against time to get medical care, to try to restore blood flow, to keep the zone of infarction as small as possible. It is this phenomenon where the zone of hypoxic injury can become infarcted that somebody might start with a subendocardial MI, start where their blood vessel is only partially occluded and they only have cell death in the subendocardial region and the rest of the ventricles in hypoxic injury. But if the time goes by and they're not getting medical care, you'll see further and further cell death. The zone of infarction will grow, and it could actually end up becoming a full thickness infarct. So time is a really important element in the story of acute coronary syndrome. And it has to be really respected in terms of acting quickly in all of PT, and you'll talk about this more in differential diagnosis. But the worse the possible other diagnosis is, like the chance that it could be a pulmonary embolism, the chance that it could be an MI, things that can actually lead to death, it's better to kind of overreact to them, send them to urgent care, call 911, react and let it get ruled out when the possibility is so bad, especially when there's this time component that the longer it takes to get care, the worse their permanent cardiac injury will be. The flip side of that is you have time. I mean, a person can experience a sudden death from a coronary artery disease, but most of the time when you've heard of somebody experiencing sudden cardiac death, more than 80 to 90% of people who have sudden cardiac death are dying from an electrical problem in the heart, what's called a ventricular fibrillation, where there's electrical instability that leads to the sudden death. So we often have a little bit of time where we'll experience symptoms and we can act and we can make an impact for our patients here. So the location of the clot tells you where the infarcted tissue will be. And we'll kind of go more into the testing of this, but let's just kind of put it out there in our notes for right now that whichever artery has the clot tells you where the MI is. So if it is your left anterior descending, the big guy going right down the front, well, that's going to be an anterior wall MI, because it serves the purpose of delivering oxygen to the anterior wall of the ventricle. So it gets the full front and bottom of the left ventricle. Whereas that circumflex artery that wraps around, so this is your lateral wall MI. It wraps around the lateral wall. It's your lateral wall MI. You can get some left atria, a little bit of the posterior wall, but that's the big impact there is your lateral wall. Your right coronary artery is going to be your right ventricle. So if that's the artery that gets blocked, your right ventricle will be affected by the MI. If someone has a left main coronary clot, MI, this is by far the most deadly, because the left coronary artery, main coronary artery, feeds basically the entire left ventricle, because that's what anterior descending and circumflex branch off of. So if someone gets a clot here, this is kind of the worst area to have an obstruction of flow. So here is a cross-section of a ventricle where you can see a myocardial infarction that did end up leading to death. What's interesting is in the bottom left corner, this white area, this is evidence of an old MI that would have occurred at some previous time. So this individual had a much smaller subendocardial MI. So you can see intact tissue right further away, but when you get to the subendocardial region, that's where the cell death occurred. But then at this time, they had a transmural full thickness, the whole entire wall became infarcted to the point where this ventricle wouldn't have been able to contract to generate a cardiac output and would have led to death. So you can see the evidence of that cell death and kind of the implication between a smaller MI in the bottom and then the massive full thickness MI. So I'm going to end this lecture here so that the two videos together kind of land right around the 2-hour mark. And I will pick up the next section for our Friday video series later this week. Hope you have a great day.